Okay, we're going to go ahead and get started. Let people trickle in over the next couple of minutes. We have a few quick introductory slides, just kind of some housekeeping stuff. We are recording this for educational and quality improvement purposes. So by participating, you are consenting to be recorded. If at any point you don't want to be recorded, you'll need to disconnect from our session here. It's helpful if you have your name or even your credentials or where you work in your profile name. So there's some information here on how to rename your profile if you need to do that. If not, don't worry about it. And then also just how to raise your hand. To do that, you hover your mouse over the Zoom window to locate the menu at the bottom. You can select participants, and then you should be able to click on raise your hand. If you have any questions about that during the meeting, you can pop something in the chat, and we've got lots of people here on the team who will help you figure that out. Something that's important while we're talking about cases and mental health and disability services is protecting people's privacy. When you're sharing information about another person, we want to avoid any identifiable information. So avoid using their real first, middle, or last name or their real initials. And don't identify their family members, friends, coworkers, contact information like an email address. And it's ideal to just de-identify examples and situations. So use a fake name. Don't provide specific age information if you can. And if you have questions about whether something is de-identified or not, you can message one of our hub team members. The hub team members, if they've got their camera on, you can see we'll have a background, has echo in the corner. Echo sessions are designed to be very interactive. The reason that they are 90 minutes is because we have a presentation of some sort, and then we'll have a group discussion. So we're hoping that you will all be able to participate and provide some input while we're discussing our case today. The key components of an ECHO session, as I just mentioned, really we're a community of practice. We're here to share knowledge, work through situations, come up with solutions. We'll have a didactic speaker, which is me for today, and then we'll have a case presentation and some feedback opportunities for questions and answers as well. Case studies. This is one of the most important parts of an ECHO session. We go through some information, someone provides a presentation, and then we work through a case study together. So we talk about how to apply that information to real life situations. You'll get to hear from peers and colleagues about what they would recommend. You will hopefully receive some valuable feedback to take back and apply in your work and similar scenarios. We are always looking for case studies to present in these sessions. They will be monthly. If you would be interested in bringing a case to our next session or any of the following sessions for us to discuss and kind of workshop as a group, you can email mhidd@aggies.usu.edu, and we'll work on getting that case presentation worked into one of our future sessions. We do have CEUs available through the Utah Social Work Association. So if you are interested in that and you'd like to receive those, you will need to fill out the evaluation that we will send to you. Janelle, is that in an email, or are they redirected after the meeting?
So I will put it in a follow-up email, as well as I'll put it into chat throughout the meeting.
Perfect. Awesome. So we'll have an evaluation. You'll need to fill that out if you'd like to receive CEUs, or if you would like a certificate of attendance. If the social work CEUs through the Utah Association won't be helpful for you, but you would like to request a certificate of attendance so you can apply that elsewhere, we can provide that as well. Either way, you'll need to fill out the evaluation, and then we will get that certificate put together for you. We will have a Canvas page put together. If you're not familiar with Canvas, it's the platform we use to put all of the information together and house resources that will help you prepare for, review, and implement anything that we discuss in these sessions. You'll have to register for Canvas to access that information if you'd like to be able to see the recordings and any of the materials that we provide. If you'd like to register for that so you can see those, you'll need to email that same mhidd@aggies.usu.edu. You'll receive some instructions on how to register, and we can add you to that page. And any questions with registration or after registration, you can submit to that same email. We're happy to help get that figured out. One element of the Canvas page that can be helpful is a discussion board. That's one way you can connect with the other participants, other people who have attended these sessions. If you have questions about material or resources, that's somewhere that you can add those questions. I am our didactic presenter for today. My name is Rachel Byers. I am a project coordinator with the Institute for Disability Research Policy and Practice up in Logan, Utah. I do have a Master of Public Health degree. I'm very passionate about public health and health equity. I'm also a certified health education specialist. I ended up working in the field of disability through obtaining a position managing supported living services in Pocatello, Idaho. And that just really opened my eyes to the need for increased efforts towards health equity and healthcare access, especially mental health for individuals with disabilities. And that just really made me passionate about this, which is why I do what I do currently. So I'm on the mental health team in the research and training division here at the Institute. And I am also an adjunct instructor for Idaho State University. I teach some of their undergraduate wellness classes. You can follow our ECHO page. We have some social media here, Instagram and Facebook. This QR code, does this take us to Instagram or Facebook? I can't remember.
I think Facebook.
Okay, perfect. So you can look up those handles, or you can scan this QR code. It will take you to one of our social media pages. There will be information about other ECHO projects we have going on, and I think upcoming sessions for this ECHO as well. So I just want to say thank you for taking some time to join. I know 90 minutes is a big chunk of time, and you all have a lot going on, but we're really glad that you joined us today. Our next session will be June 12th, and that one will be mental health literacy for direct support professionals. So if you are interested in that, if you haven't registered already, please do. We'd be happy to have you join that as well. All right. Okay, with that being said, let's go ahead and get started with this didactic presentation for today. We'll be looking at the history, terms and definitions, and implications for disability service providers surrounding dual diagnosis. So individuals who have a disability diagnosis as well as a mental health concern. And just some quick disclosures. I am an employee of the IDRPP at Utah State University. We are a university center for excellence in developmental disabilities. From this didactic presentation today, and then as well as discussion for the case scenario, we're hoping that you will be able to describe the overall prevalence of disability and the most common disability types in Utah, define and describe the term dual diagnosis, describe the prevalence of mental health concerns among individuals with intellectual and developmental disabilities, describe some of the historical elements of the treatment of people with disabilities, and then understand or define and describe the term diagnostic overshadowing. And I know that sounds like a lot. I do think we'll be able to get through it all today. So hopefully this will be useful information for you all. Before we really dive into talking a lot about disability, I wanted to review quickly the different disability models or frameworks that we have to view disability. There are two primary ones, one being the social disability model, where disability is considered to be caused or kind of resulting from the structure of society. So it's not an inherent issue with the individual. And when we're looking at disability through the social model, we work towards universal design, things that benefit everybody regardless of ability. And we work to promote education and accommodation so that everybody can participate fully in society. The medical model of disability views disability as more of a defect of the individual or something to be cured or fixed, as it's the responsibility of the individual. We here at the Institute rely and prefer the social model, where disability we acknowledge is something that is created and influenced by the structure of society. Given that there are these different models and different ways to view disability, there are still official definitions that we use to describe disability. And this one from the CDC is that any disability, a disability is any condition of the body or mind, they call that an impairment, that makes it more difficult for the person with the condition to do certain activities, which they call an activity limitation, and interact with the world around them. And they call those participation restrictions. So that is one of the official government definitions of disability. This project specifically, the ECHO-MHIDD project, Mental Health and Intellectual and Developmental Disabilities, places an emphasis on intellectual and developmental disabilities. So that being said, developmental disabilities, and this is the official definition from the CDC as well, are a group of conditions due to an impairment in physical, learning, language, or behavior areas. These conditions begin typically during the developmental period and may impact day-to-day functioning, and they usually last throughout a person's lifetime. Developmental disability is a very, very large umbrella, covers a lot of diagnoses. Up next here, intellectual disabilities are a more specific subset that fall under the developmental disability category. And intellectual disability, officially, as defined by the AAIDD here, is a condition characterized by significant limitations in both intellectual functioning and adaptive behavior that originates before the age of 22. So one way to look at this is that intellectual disability, all intellectual disabilities can be considered developmental disabilities, but not all developmental disabilities are intellectual disabilities. Typically, though, we use the term IDD, we connect them, intellectual and developmental disabilities, typically as an umbrella term to describe disabilities that develop during childhood and usually require lifelong supports and services. So you're probably familiar with a lot of these diagnostic terms here, but these are examples that would fall under the umbrella of IDD. You have autism spectrum disorder, Down syndrome, spina bifida, cerebral palsy, fetal alcohol syndrome, and attention deficit hyperactivity disorder, or ADHD. These are all examples of diagnoses that would fall under that umbrella of intellectual and developmental disability. I think it's important for us to have an idea of what disability looks like in Utah. How many people here in Utah have a disability? The most recent numbers that we have from the state of Utah show that almost 600,000 adults, which is about 1 in 4, identify as having a disability here in Utah. That's a very large percentage of the adults. 1 in 4, 25% of adults in Utah have a disability. And when it comes down to looking at what types of disability these adults have, the most common reported is cognitive, which likely falls under the umbrella of IDD, probably an intellectual disability. So we know that 1 in 4, almost 25% of Utah adults have a disability, and the most common among that group is cognitive that's reported, probably falls under that IDD umbrella. So we know that there's a large portion of adults in Utah who have a disability that falls under there. Dual diagnosis is a term you might have heard before. It's a term used to describe individuals who have an intellectual or developmental disability diagnosis in addition to experiencing mental health concerns, whether that's a diagnosis of a mental health concern or experiencing signs and symptoms of a mental health concern. That term dual diagnosis means presence of a disability as well as a mental health concern or concerns. How common is dual diagnosis? The short answer is it's very common. Estimates definitely vary based on what source you look at, but more recently we've kind of solidified around 40%. So approximately 40% of people with IDD diagnoses experience mental health concerns as well. And for individuals on the autism spectrum, it's closer probably to 70%. So we know a very large portion of adults in Utah have a disability, and it's likely that a large portion of those adults also experience mental health concerns based on the data that's available. And if that individual has autism, it's even more likely that they're experiencing a mental health concern. In our own data collection, our ECHO-MHIDD project, we conducted a landscape analysis, and we asked people with disabilities if they experience symptoms of anxiety or depression or other mental health concerns. More than 50% of the individuals we asked reported experiencing symptoms of anxiety and depression. And I'll show you that here, what that breakdown looked like. And I'd like you to just take a look at this for a second. I've highlighted in a lighter blue symptoms of anxiety or depression. And that orange bar you'll see is thoughts of suicide or death, which was 22%. That's almost 1 out of 4, almost a quarter of our participants to this survey reported having experienced thoughts of suicide or death. And more than half had experienced signs or symptoms of anxiety or depression. So a quick question for us to think about for a minute is, how has dual diagnosis been addressed in the past? In the United States, how have we provided services for people with disabilities and mental health, and especially when those intersect? The answer is, unfortunately, not very well. So we're going to provide a little bit of a historical picture here to help understand how our disability service system has been shaped and how people with disabilities, particularly intellectual or developmental disabilities, as well as mental health concerns, were treated in the past. We have documentation over thousands of years of people with disabilities living across different cultures. Depending on what part of the world they were in, there were different beliefs and perspectives, and we see through historical documents that those beliefs and perspectives changed over time. It was different from geographic location, definitely influenced by societal norms and religious beliefs. In the Middle Ages, so thinking a long, long time ago, documentation that we have indicates that people with disabilities were used for entertainment. Primarily, they were abandoned when they were considered no longer useful, so treated very, very poorly in the Middle Ages. And as we fast forward a little bit, get closer to the United States, we adopted a lot of our disability beliefs and perspectives from Europe. In early US settlements, there were some behaviors or habits that US settlers used to avoid having people with disabilities in their communities. A couple of these approaches were warding out. They would say people with disabilities aren't welcome here, move on, which is some of that passing on or bidding out process. They would collect people with disabilities and move them into other communities because they did not want them in their settlements. And there were a lot of other damaging practices that were used early on in the United States to try and, quote, fix people with disabilities, such as trepanation, where you would drill a hole in the skull that was supposed to get rid of evil spirits or cure people. of disabilities. So for a long time, for probably hundreds of years, and then early on in the US settlements, people with disabilities were not treated well in Europe and here where we based ourselves on those. And unfortunately, it gets even a little bit worse. We, in the United States, definitely promoted the belief that individuals with disabilities and or mental illnesses were less than others. They were often ostracized from the quote normal groups in society. We eventually ended up institutionalizing groups of individuals, people with disabilities and people with mental health concerns, and especially those who experienced both were often institutionalized, put into a group together, and even sterilized. There were movements where people with disabilities were sterilized and encouraged not to engage in romantic relationships, or they were considered incapable of having families and were encouraged not to do so. They were also included in this legalization of segregation in 1896. It promoted that idea of separate but equal. They would institutionalize people with disabilities and people with mental health concerns. And say, yeah, you're equal. We're just going to put you over here. But ultimately, they were treated very, very poorly. This picture, I think, speaks volumes. I hadn't seen this until I worked here. This was something I had no idea had existed or was a problem in the history of the United States. This was a campaign on eugenics that was run, I think, in the southeastern United States. But essentially, the idea that was promoted here was that people with disabilities will become criminals. They are a burden to society, and they should not be allowed to continue. And they were discouraged from forming romantic relationships and having families and that autonomy. And these slides we will put in the Canvas page so that you can have this picture if you'd like. For a long time, societal problems were blamed on the quote feeble-minded, typically individuals with intellectual or developmental disabilities. And again, that eugenicide. Hitler's eugenics policies were definitely influenced by prominent US eugenics scientists and the idea that people who are viewed as less than, including people with disabilities, were not welcome. We started to make some progress in the 70s. We started working towards deinstitutionalization and some special education process. If you're familiar with Willowbrook, there's a lot that we could dig into there, but essentially there was an expose in the 60s or 70s where a reporter went into an institution and exposed the very, very poor treatment that was occurring there and brought that to the attention of the public. It took even more work than that, though. People were horrified by that, but just being horrified by something doesn't lead to change. So it took definitely several decades to work towards deinstitutionalization. And that was as recent as the 70s, which really in the grand scheme of things was not that long ago. So we think about what are we doing now and how does all of that and how has all of that influenced our structure and our system, and how does that influence the lives of people with disabilities? Currently, we operate primarily here in Utah on a Medicaid waiver system. We are trying to work towards full inclusion and full autonomy for people with disabilities. For a community to be open to inclusion, it really requires a society to reflect the true diversity of its population. So when an entire segment of the population is non-existent or funneled somewhere else, in this case, people with disabilities, it communicates this expectation that that segment does not belong, that they are not or should not fully participate. We are still working on achieving a truly integrated community life for people with disabilities. We still have kind of siloed people with disabilities. There is still difficulty in fully communicating, fully participating in community life. We're still working on that. even now. So just let that sink in for a moment. Think about that, those historical elements, what has led up to where we are today. Think about your experiences with the disability service system yourself and what you have seen. All of that being said, we know how many people, at least adults in Utah, report having a disability, and how many adults approximately also experience mental health concerns. That term, dual diagnosis, meaning an individual who has a disability and also experience a mental health concern or multiple mental health concerns. There's another important term when we're talking about dual diagnosis that we understand, and that term is diagnostic overshadowing. Diagnostic overshadowing happens when symptoms and signs of a mental health concern are attributed to an individual's intellectual and developmental disability diagnosis, rather than being attributed to a very valid and legitimate mental health concern. And when that happens, when those signs and symptoms are dismissed as being due to the disability or intellectual disability, that leads to unaddressed mental health concerns, which can then lead to worsened outcomes for that individual. So diagnostic overshadowing is important when looking at the disability field, especially with dual diagnosis. If diagnostic overshadowing occurs, the individual experiencing that is likely going to experience far worse outcomes than they should. They're probably not going to receive the care that they need. So we do have some recommendations for disability service providers. What does dual diagnosis and diagnostic overshadowing and that history of disability, what does that mean for disability service providers? How do we take that information and try and make some meaningful change? One thing we can do as disability service providers is raise awareness among our staff and direct support professionals that our participants and clients with disabilities also definitely experience mental health issues like the typical population. There is sometimes a myth perpetuated out there that people with disabilities, especially intellectual and developmental disabilities, cannot or do not experience mental health concerns. And we know that is definitively not true. So it's important that our staff, our direct support professionals understand that and are aware. We can provide training to DSPs, our case managers and other staff on what dual diagnosis is and what the prominent issues and trends are. And I'll talk about that a little bit more in the next slide. That is something that we are working on in this project specifically. So if you are interested in having training for your direct support professionals, you can reach out to us and we can discuss that more. We also, thinking about diagnostic overshadowing, we should not assume that problematic behaviors or issues are related to disability. We need to also consider the mental health component there. Is there a mental health concern that's influencing behavior or affecting behavior? And then we should also talk to our clients and participants about mental health, help them develop awareness of mental health concerns, how to notice signs and symptoms of a mental health concern, and how to address those as best as we can. You may already be very familiar with disability-related resources here in Utah, but if you are not, it would be helpful to become familiar with those resources that might be able to help connect you and your participants to essential mental health services. So, as I mentioned, you can reach out to us. We have this ECHO-MHIDD project. It will be going for another 3.5 years, and one of our objectives is to provide training for direct support professionals to help address this issue and improve mental health care access. So if you need staff training, reach out to us. We'll see what we can do for you. The Utah Department of Health and Human Services is also making a lot of efforts right now to address mental health concerns for people with IDD. There is a webinar series currently for mental health providers being run by the Department of Health and Human Services. There is the Disability and Health Program as well. So there are a couple different resources through the Department of Health and Human Services that are looking to bridge some of these gaps, and you may find those useful. It would also be helpful, and you may already be familiar with these as well, with mental health providers in your area. And this we know will vary dramatically based on where you are geographically, the number of providers that are there, the types of providers that are there. If a provider declines to provide services for someone with a disability because they don't feel comfortable or confident in providing those services, you can refer them to us for resources and training, and we will do absolutely everything that we can to help build that comfort and confidence in providing those services so that they can expand to reach that population. That is another goal of our project here for MHIDD. We've learned through our landscape analysis that disability service providers and direct support professionals can definitely benefit from some training and education, but that it needs to be a kind of a two-pronged approach, supporting mental health providers and disability service providers. So we'll be providing some training and education for both groups. We have a couple helpful resources here for disability service providers. We had a previous project that the Institute was a part of, very similar to this one, when MHDD, the Mental Health and Developmental Disabilities Training Center, has some training modules that are very helpful, talking about dual diagnosis, and NAMI as well, especially looking at identity and cultural dimensions. And then the CDC has a disability and health page where they explore mental health and people with disabilities as well. And again, these slides will be on that Canvas page. So if you'd like to access these, you can sign up for that Canvas page and you'll be able to see these slides and these links. And one of the last notes here, in our landscape analysis, we asked people with disabilities, do you feel like disability service providers value your mental health needs enough? And the result was about 50-50, yes and no. I do want to note, we know that disability work is challenging, and we ask a lot of disability service providers. So with that in mind, just thinking about the perspective of people with disabilities who are in disability services, they feel about 50-50 split that their mental health needs are valued enough. I just think that's something we should think about as we're looking to address mental health for individuals with intellectual and developmental disabilities. If you'd like to learn more about any of these topics, or you're interested in discussing potential trainings, you can reach out to myself or Matt Wappett. Matt is the director here at the Institute, and he is by far the professional between the two of us. So we will absolutely provide as much help and connect you to as many resources as we can. Matt, I wanted to ask if there was anything you would like to add or elaborate on from my presentation. Any notes?
Nope, I don't think so. I think you did a great job. I do think it's important to note that, as Rachel pointed out, although historically we haven't done a good job at addressing these issues, it is hopeful to see that there is an increasing awareness and increasing number of resources and initiatives to address these issues. And I do think it's important to keep in mind that individuals with intellectual and developmental disabilities do experience the full range of mental health issues that the rest of us do. They just may not be able to communicate or may not experience them the same as somebody who may be typically developing. But it is important to acknowledge that this is an important part of being human. And just like the rest of us need mental health supports and need people to acknowledge our lived experience, I feel that it's important to do the same for the individuals with disabilities that we support, live with, care for, and work with. So anyway, but no, that's all I want to add there, Rachel.
Great, awesome. Thanks, Matt. I think we do have a couple of minutes if we have maybe a few questions. Is that right, Janelle? Do we have a little bit of time?
Yep, you certainly do.
So if you do have any questions, we can take a few minutes. Feel free to put it in the chat or raise your hand. If not, we will move ahead to our case presentation for today. And our case presenter today is Jamie Withrich. I will stop sharing my screen so we can get that rolling.
Okay. Give me 1 second here. Okay, can you guys see that?
Yep, looks great.
Great. Okay. Thanks. So my name is Jamie Withrich. I work for the Division of Services for People with Disabilities. I'm also a licensed clinical social worker. Just a little background on what DSPD does in case anyone's not familiar. So DSPD is a state agency. We pay contracted providers to support people in the community. So when you think about someone who's utilizing DSPD services, there are individuals who may be at the Utah State Developmental Center, which is a different setting than what we'll be talking about. These are individuals who have DSPD services who are in the community. And the individual I want to talk about is someone in their late 50s. I am trying to, sorry, let me. So this individual was diagnosed with adjustment disorder with mixed anxiety and depressed mood, as well as a mild intellectual disability. And in her situation, she had relationships, but she didn't really have any healthy relationships, and she didn't really have any family members who were involved in her support. I'm having a hard time. There we go. Okay, so she lived out in the community. She had her own apartment. Unfortunately, while she was in the community, she was frequently victimized by members of the community. So some of the things that were going on is she had a lot of house parties that she didn't typically invite people to, where drug use occurred pretty regularly. After that, her home was frequently burglarized. And one of the more concerning things is that when staff were going into the home, they noticed that she had injections where an individual who was living with her had been injecting heroin. So the staff who were supporting her made regular APS referrals. DSPD made APS referrals, and I'll talk a little bit about what happens with that. Just to clarify what she wanted. So she really wanted to live independently in the community, which is a right that she should have. Her support team saw that as very important for her as well. And so we all worked to kind of keep her in the community. But some of the issues that came up while she was in the community was that when APS would go out to investigate some of these cases, she just wasn't willing to participate in the investigation, and they really can't force a person to disclose anything that they don't want to. So APS they had their hands tied in regard to the support that they could provide. Welfare checks happen pretty regularly, but unless the person living in the home had a warrant, it wasn't often that a roommate or someone who was kind of just living there without paying rent, they could stay as long as they didn't have any warrants or any reason to not be there. So it was really difficult to support her and keep her in a safe setting. Just to be clear, civil commitments with individuals in DSPD are not exactly like what you are probably familiar with mental health civil commitments. So once someone's civilly committed, really the purpose is to keep them, so they're receiving DSPD services, but we can't force a person to move. So we couldn't say, well, you're in this apartment now, but under a civil commitment, we're going to pack all your things and you're going to move into a group home. So that was part of our limitations with the civil commitment. And just to be clear, there are a lot of people in DSPD services who want to live independently in the community. Unfortunately, if they don't have a lot of strong natural supports, there's people out there more probably than you think that do recognize that person has a disability and they take advantage of them. So without any kind of education, people with disabilities who want to reside in the community and should, there's a risk to them. And just to understand that this individual had already lived in a group home. So she didn't want to go back into a group home. She wanted to live independently in the community. She could. She was working, she took the bus to work, and she really could support herself and live independently. It wasn't her needs, it was more about the people that targeted her. And she did have some pretty serious mental health needs, and she had some suicidal ideations, so she was in and out of behavioral units, but the mental health services that are offered through local mental health authorities aren't really designed to tackle some of the issues that she was coming up with. And just to reiterate, it's very important that people with disabilities who choose to live in the community without staff there in the home at all times have the right to do so. And there are a lot of people who want that. So just some of the things to think about as far as with this situation and some of the others that we run into is that self-advocacy education isn't regularly available. Internet safety. So a lot of women that we see, men as well, but women getting trafficked or meeting people who take advantage of their finances because they're not understanding that they're talking to someone who's trying to victimize them. And then just the basic, like understanding boundaries, understanding your own sexual rights, having an intimate relationship, but doing so in something that's consensual. Those kinds of trainings aren't regularly out there. And then we're talking about people with co-occurring situations. So you're talking about a person with a disability as well as a mental health need. And so they are at greater risk for victimization. And I don't know if you guys need me to post the questions. That's the next part of this. I'll just pop that up there. And I didn't, Rachel, I didn't combine the last two, just a heads up.
Oh, that's fine.
That's all I've got for my case study, and unless you guys need more from me.
Awesome. Thanks, Jamie. So to kind of recap, we have an individual who wants to live in the community, is not interested in living in a group home. They'd like to be as independent as possible. They are experiencing mental health concerns. They do have a disability, but we're running into perhaps they're being taken advantage of, mistreated by community members, even so far as drug use and partying on their property. But they are also not open to working with adult protective services. So there are a lot of nuances to this case. Would you say that summarizes it decently, Jamie?
Yes, thank you.
What we're going to do now, if you have any clarifying questions about the case, something that might help you think through it a little bit more and answer our community discussion questions, you can unmute and ask those or type those into the chat. If you don't have any clarifying questions.
Rachel, Debbie Builder has her hand up.
Oh, perfect. Yes, Debbie.
Yes. So Jamie, is hearing about the injections that you're seeing that she's being injected with heroin, to what degree is her refusal to speak with APS or her fear of going through withdrawal of heroin? Do you have a sense for that?
I had met with her shortly after, and this was kind of irregular. So this was part of someone who was staying at the home. The other concern was that she really felt like if she were to admit that something were happening, that she would end up going back to the group home. So that was her bigger fear was, well, if I disclose anything, then I'm going to have my freedom taken away from me. So it was difficult to even get her to discuss what happened.
Thanks, Jamie. If there are any other clarifying questions, feel free to pop them in the chat or raise your hand. Otherwise, what we are—
I have another question.
Yes, go ahead, Jen.
So I'm assuming with the parties, was she getting complaints from neighbors? And so I'm just wondering what other pressures may be pulling into this situation beyond her control that could potentially facilitate change without taking away rights of hers.
She definitely had neighbors complaining, and the living situation when people moved in, the house was really difficult to even visit. There were so many animals in the home that it was hard to even stay there for even a few minutes. But outside of adult protective services and contacting the police and her unwillingness to participate with any protective agency, it just kind of left this gap as far as how to step in and assist her. There were people around that were witnessing what was happening. They were concerned, and they were speaking up on her behalf. But the fear, I think, for her of losing the ability to live in the community was enough that she just wouldn't disclose, and nobody was really responding to protect her.
I also have a quick question, if that's okay, Jamie. And I may have missed this, but so clearly she qualified for disability services. Did she have a formal mental health diagnosis?
Yes, she did. And I can't tell you exactly what it was
That's
because
okay.
it's in the slides and I've already forgotten it, but it was,
Yep.
she did have, and she also had issues with suicidal ideation and
Right.
attempts.
I remember the suicidal ideation piece. Okay, thank you. Sorry, I must have missed that.
Any other clarifying questions?
Jamie, does she have a history of trauma? Just wondering her propensity towards allowing, it's beyond what I often will see with those with neurodevelopmental disabilities.
A significant trauma history.
All right, so what we'll do now, we're going to split up into some breakout groups. Each group will have a question about the case to discuss and come up with some solutions and recommendations. Each group will have a facilitator from the hub team. We'll make sure that we have the question. If you could please turn on your cameras, it will help us engage in conversation a little bit more if you're able to. And Sarah, if you'll help us get split up into those, we can go ahead and get started. All right, welcome back. I think everybody who stayed on is back. We have 15 minutes left, and what we'll do is go through our recommendations that we talked about as a group for our questions and make sure we addressed all of those case questions and see if there's anything else we need to wrap up. So question 1 was, where can a person with an intellectual disability and or a neurodevelopmental disorder go to learn about safe, independent living? Is there someone from that group that'd like to talk about maybe the recommendations you guys came up with?
Yeah, I'm going to go over the recommendations. And then offering anyone from my group to jump in if I miss something. So we talked about accessing independent living centers using your support team. And if you don't have a support team, using your natural supports to build a support team. And then we talked a little bit about Davis Behavioral Health, who has a housing program where you can connect with a therapist and access medications. This is more, they have two kind of programs. They have more of an independent living one where you're living in your own apartment and a case manager checks on you. And then there is another one where it's more of an dorm-like setting where you're sharing space, your kitchen, your bathroom, and the caseworker stays there. And this is typically for individuals who can do their own ADLs. So we talked a little bit about how some individuals might not be able to access a program like that. Also that it's heavily utilized, so it may not be easy just to jump into a program like that. They felt like that the program does treat individuals who have both an intellectual disability and mental health conditions. But we talked a little bit about the disconnect between people who do have services to address their ADLs, like home health supports through state Medicaid, and how those services could be utilized in a mental health setting, mental health housing setting, like we discussed, where we believe those things occur outside of Davis Behavioral Health. So maybe looking at these separate services and making sure that they're combined and offering support so it's a little more comprehensive. And I think I captured it all, but if I missed anything, please speak up.
Awesome, thanks, Jamie. And my group had question 2, which was that some people with disabilities may not have family members or safe friends to rely on for support. So where can those individuals with co-occurring diagnoses meet other individuals who have similar lived experiences in a safe way? We also talked about Davis Behavioral Health. They have a praxis house where people can meet as a group, hopefully safely. We also talked about establishing connections through trusted avenues that are aside from family and friends, maybe a church group or a social group that you have already established trust with. And then as well, the internet is both a blessing and a curse. We have seen clients and participants be in not so great situations on the internet, maybe being taken advantage of or mistreated by people on the internet. But we also think there are some opportunities, especially for individuals where transportation might be an issue. There are hopefully some opportunities on the internet for group connection and discussion, and definitely hopefully some self-advocacy and involvement with those groups that have similar experience. So then I started Googling. I was looking for specific groups, trying to find if those groups even exist. I have not found any yet. That was really, really quick, but we did think that was one potential avenue, especially for situations where travel is a challenge or transportation is a challenge. And then our last group, how does an agency honor choice and allow a person to make and learn from mistakes safely, and where is that threshold? I think this is one of the hardest questions, so I'm curious to hear your guys' thoughts on that.
Who is speaking from our group? We didn't decide? Me? Oh, I see Janelle saying me. Okay, great. I didn't take the notes. We had a good conversation, and I think the big thing that we came up with came from Ashley's insights around peer support. One of the issues that this population struggles with is, right, informal peer supports, friendships, right? Having friendships and healthy relationships. And a lot of times we find individuals, you know, because they struggle with that, going to less healthy relationships, as in this case. And so Ashley brought up the peer-to-peer support model, right, which is common within mental health, but which is not used within the intellectual and developmental disabilities world. And, you know, whether that's a formal peer-to-peer model, which is a mental health support model that's used around substance abuse and other things, or whether it's an adapted model, which we talked about. There's not really any. I guess there's one that Ashley's been looking at that's been adapted potentially for this population. But really helping people develop healthy relationships, right, with peers, so they have that social support and they have friends who can help them think through, right, their choices and help them make smart, wise choices. I mean, that's huge for the substance abuse community, right? Having a peer when you're struggling that you can reach out to, who understands and who can help you make smart choices, is really helpful, and it could be helpful for this population too. So anyway, just helping people get connected in healthy relationships, I think, was the big finding we came up with. The other thing that I was waxing philosophical on is the fact that we often don't allow people with intellectual and developmental disabilities to make choices. Oftentimes those choices are made for them, and as a result, they don't have practice exercising their agency. And, you know, and again, we see this in the research through special education, adult services, everything else. A lot of times people with disabilities live highly controlled, highly structured lives. And making choices is a skill that we learn through trial and error. And so again, providing opportunities for people to make choices within a controlled environment where they can learn from those decisions, I think, is important. And, you know, I was talking that that's an important role for a support coordinator or a case manager to help people identify what are their goals, what choices do I need to make to reach those goals, and everything else. I don't necessarily think the support coordinators and case managers do as good a job at that as they could, and yet that's an important part of, I think, what they could bring to the system. So anyway, Ashley, Janelle, Thelma, did I forget anything?
The only thing I have that I thought that was so cool from ours is that Meetup online app where you can identify hobbies, and Ashley shared that information with us. So.
Awesome. Thank you. I want to make sure that we've got all of these recommendations noted so that we can summarize and send these out. This is something we'll also have on the Canvas page. We'll have the recommendations notes compiled and accessible there. So you can come back to those if you end up needing help in a similar scenario or with a similar case. So for question 1, where can a person with an intellectual disability and or a neurodevelopmental disorder go to learn about safe, independent living? We suggested accessing independent living centers, using your support team or using your natural supports to build a support team, accessing those. And question 2, where can individuals with co-occurring diagnoses meet other individuals who may have similar lived experiences safely? Accessing services like Davis Behavioral Health Praxis House, established places that have some structure and support where you can go and be with groups of people with disabilities to share that lived experience. Establishing connections through trusted avenues. They may not be family or friends, but social groups or church groups that you feel are a safe space. And then online, although it can be tricky, you may be able to access, and that I think goes kind of with what Ashley had recommended, finding those communities online. And that's helpful in situations specifically where transportation can be a challenge. And then question 3, how does an agency honor choice and allow a person to make and learn from mistakes safely? Where's the threshold? And there's a lot there. I really appreciated what you guys brought up. Peer support is definitely valuable. I think it got me thinking more about how we can maybe implement that more in the disability field, and helping people develop healthy relationships and go through that exercise of decision making and learning those decision making skills. Did I miss anything there? Anything else we need to add? No, we're all set. Okay, like I said, we'll summarize those. Those will be on the Canvas page as well. Thank you all for coming. We are right on time. Thank you so much, Jamie, for preparing that case and helping us walk through that today. I think that was useful. Again, our next session will be on June 12th, same time, 11 a.m. Mountain Standard Time till 12:30 p.m. And that will be the mental health literacy for direct support professionals session. So if you have anyone interested, refer them this way. That will be primarily for disability service providers. Yes, Ashley.
Do you have a case presentation for next month, or do you guys need one?
Matt, if you have one for that one that you think would be good, other than that, we are always open to case presentations though.
Okay.
So if you have one, send it out.
If you have one, Ashley, yeah, why don't we, let's talk and we can kind of see what we got.
Awesome. All right. And that evaluation we'll send out in the email. Was also, Janelle dropped that link in the chat. If you'd like a certificate of attendance, or if you'd like that CEU certificate from the Utah Social Work Association, make sure you complete that evaluation and we'll get it sent out to you. Janelle, is there anything else I need to do to wrap up, or can we let everyone go just a few minutes early?
You are good.
Okay, perfect. Thanks again, everyone. This was our first session, so we'll definitely come back prepared, I think, a little bit better for the second. Thanks for attending. I hope that you learned something valuable and share the word about our upcoming sessions, and we'll see you then.
Thanks, Rachel.